Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Coherus Biosciences.
Crafting your practice, and let's navigate some of the data in nasopharyngeal cancer. This has really been a rapidly evolving space over the last couple years. Nasopharyngeal cancer is primarily diagnosed with local regional disease in the US. About 54% of cases are diagnosed with regional spread, 13% with distant metastatic disease, and the remaining with local only disease. Among Eastern Asian populations, a greater proportion is diagnosed with advanced local regional or distant metastatic disease. But all in all, a large portion of these patients do come in with local regional or distant metastatic disease at diagnosis. How have we come to where we treat patients with local regionally advanced nasopharyngeal carcinoma? The Al-Sarraf study, which was the intergroup study 0099, was published 27 years ago. And this really established the current standard of what is the long-standing standard of care in this patient population. This study took patients with local regionally advanced nasopharyngeal carcinoma and randomized them to concurrent chemoradiation with cisplatin, followed by adjuvant 5-FU and cisplatin versus radiation alone. And the patients who received the additional concurrent and adjuvant chemotherapy had a dramatically improved 3-year overall survival, which you can see, from 78% to 47%. For 20 years, this was the standard of care for patients with upfront non-metastatic nasopharyngeal cancer, regardless of EBV status. In the more recent years, we've seen a trend in studies towards induction chemotherapy in several studies, including the two shown here from Dr. Sun and Dr. Zhang, which have really changed the standard of care and altered how we think about managing patients with nasopharynx cancer. The study from Dr. Sun in 2016 took patients with local regionally advanced nasopharyngeal carcinoma and randomized them to TPF induction chemotherapy, followed by concurrent chemoradiotherapy with cisplatin versus standard chemoradiotherapy alone. And they noticed that the 3-year failure-free survival was significantly improved for patients receiving induction TPF, which led to further research into alternative induction strategies, as TPF is quite a challenging chemotherapy to get patients through. So Dr. Zhang and his colleagues in 2019 published this study, which evaluated the role of induction gemcitabine and cisplatin versus concurrent chemoradiotherapy versus chemoradiotherapy alone in this patient population, and found a significant benefit in not only progression-free survival, which increased by about 10%, but also overall survival, which increased by about 5%, establishing the standard of care, at least for EBV-positive patients, as this study was done in China, where the overwhelming majority of patients on the study had EBV-related disease, to be induction gemcitabine and cisplatin, followed by definitive chemoradiotherapy with concurrent cisplatin. It remains a Category 2A recommendation for patients with non-EBV-related disease, and I think there's some more practice variation around that, but certainly for patients with EBV-positive disease, this is the standard of care. It's also important to note that we're very good at curing this disease now. What is you can see in 25 years in studies looking at relatively similar patient populations, we've moved from a 3-year overall survival of 50% with radiation alone to 80% with chemoradiation to 95% with gem-cis and induction gem-cis and concurrent chemoradiation following that. So really quite an improvement in the long-term prognosis of these patients. But as with most other solid tumors, immunotherapy has changed the landscape. I'm sure that most of you in the oncology space are at least aware tangentially of how immunotherapy works at this point. But PD-L1 on the tumor cell typically binds to PD-1 on an activated T cell, which can induce that T cell to kill the tumor cell. And that, or sorry, blocks that T cell from killing the tumor cell. But these PD-1 inhibitors are able to bind to PD-1 on the T cell, prevent it from being downregulated or blocked by tumor cells, and allowing it to still kill these tumor cells. Immunotherapy is now standard in a wide variety of solid malignancies, and nasopharyngeal carcinoma is no exclusion to that. There have been several studies here that are relatively small that have started to build an evidence base for the use of immunotherapy in nasopharynx cancer. The Continuum study evaluated a PD-1 inhibitor, sintilimab, with the addition of induction chemotherapy plus concurrent chemoradiotherapy versus induction chemotherapy plus concurrent radiotherapy alone, and found that the addition of sintilimab to the neoadjuvant approach improved 3-year event-free survival. In the adjuvant setting, the DIPPER study evaluated camrelizumab, another PD-1 modulating drug, plus minus observation following induction chemotherapy versus concurrent chemoradiotherapy in local regionally advanced nasopharyngeal carcinoma, and found that adjuvant camrelizumab improved 3-year event-free survival, again by about 10%. An even more novel approach, the Diamond trial, which was presented earlier this year, evaluated toripalimab with induction chemotherapy with radiation alone versus induction toripalimab plus induction chemotherapy versus conventional chemoradiotherapy with concurrent cisplatin, i.e., asking the question, with the addition of toripalimab, are we able to remove the cisplatin from concurrent chemoradiotherapy? Cisplatin does add meaningful toxicity to this, especially to hearing and renal function, and is not only that, it's a burdensome to patients as it's a 5 or 6 hour infusion for most patients, depending on your infusion center. So it is a very reasonable question to ask. And they found that the 3-year freedom failure-free survival was essentially equivalent between the two arms. It met their pre-specified non-inferiority boundary and established that we could potentially give toripalimab to replace the cisplatin in patients undergoing definitive care with neoadjuvant therapy for their local regionally advanced nasopharyngeal carcinoma. Moving to the recurrent metastatic space, so now not in the upfront definitive curative intent patient population, moving into patients who either recurred after definitive treatment for their local regionally advanced disease or diagnosed with de novo metastatic disease. Several studies have established multiple different immunotherapies as effective in this patient population and have FDA approvals and are in the NCCN guidelines. The first and most critical is toripalimab, which was evaluated in the Jupiter 2 study, which asked the question of can the addition of toripalimab to gemcitabine and cisplatin improve PFS in patients with recurrent metastatic nasopharyngeal cancer. This was a randomized, double-blind, placebo-controlled phase 3 study, and it found, as you can see in the Kaplan-Meier plot on the right, that the addition of toripalimab in the blue line significantly improved progression-free survival over placebo in this patient population. These patients had relatively similar rates of adverse events, which are relatively high because GemCis does have meaningful side effects associated with it. And there were higher immune-related AEs with the addition of toripalimab, primarily hypothyroidism, pneumonitis, and rash, which are consistent with what we see with the majority of PD-1 inhibition drugs on the market. This led to an FDA approval in October of 2023 in combination with GemCis in the first-line treatment of adults with recurrent metastatic nasopharyngeal carcinoma, and as a single agent for the treatment of adults with recurrent unresectable or metastatic NPC with disease progression after a platinum-containing chemotherapy. It's also the NCCN first-line recommendation in this setting. Several other drugs have had similar studies showing their efficacy, reinforcing the role of PD-1 inhibition in this setting. The Captain first study evaluated camrelizumab, another PD-1 inhibitor, to the addition of Gemcis, again in a very similar patient population in patients with previously untreated recurrent metastatic nasopharyngeal carcinoma. This was again a randomized, double-blind, placebo-controlled phase 3 study and found that the addition of camrelizumab improved progression-free survival by about 3 months with a hazard ratio of approximately 0.5. This was statistically significant. And again, very high rates of treatment-related adverse events, and the common immune-related AEs were commonly seen with camrelizumab, such as hypothyroidism, pneumonitis, and rash. Additionally, there's tislelizumab, which was evaluated in the Rationale 309 study, which was yet again a very standard design, very similar to the first two. Again, a randomized double-blind placebo-controlled phase 3 study. This study did allow crossover if the investigators considered it beneficial, and it also allowed continuation on PD-1 monotherapy if the investigator considered it beneficial. Again, as you can see in the Kaplan-Meier plot, the black line is better than the green line, and the median PFS was 9.6 versus 7.4 months with a hazard ratio of 0.5, again suggesting that the addition of tislelizumab improves PFS in this patient population, again with a slightly lower treatment-related adverse events, about 80% of both arms, but the same common immune-mediated AEs, hypothyroidism, and rash. Looking at more standard, I guess they're not really older, but not really old immunotherapies like pembrolizumab. The Keynote 122 study evaluated in patients with EBV positive recurrent metastatic nasopharyngeal cancer after platinum-based chemotherapy. So after they've progressed on platinum-based chemotherapy. Does pembrolizumab work better than a dealer's choice of capecitabine, gemcitabine, or docetaxel? And they randomized these patients 1-to-1. And as you can see in the Kaplan-Meier plot on the right, there was not a significant difference in median overall survival between the two, 17 months versus 15 months, though the grade 3 treatment-related adverse events were significantly lower with pembrolizumab, 10% versus 44%. Suggesting that this is a dramatically more tolerable treatment for patients with similar efficacy. Additionally, in a similar patient population, we have penpulimab. This study, the AK-105-304 study, evaluated if adding this drug, another PD-1 inhibitor, to platinum-based chemotherapy in patients with either recurrence after upfront local treatment for their local regionally advanced nasopharyngeal carcinoma or de novo metastatic disease, improved progression-free survival in this patient population. These patients were given penpulimab plus cisarcarboplatin plus gemcitabine every 3 weeks for up to 24 months versus placebo, and crossover was allowed upon progression. And you can see that in the upfront penpulimab arm in blue and the Kaplan-Meier plot on the right, the progression-free survival was significantly improved over the red dashed line, which was the placebo arm. And the PFS improved from nearly 10 to 7 months with a hazard ratio of 0.45, again with similar grade 3 treatment-related AEs, and again the common immune-mediated AEs that we see, hypothyroidism, rash, and pneumonitis. This led to an FDA approval earlier this year in combination with either cisplatin or carboplatin and gemcitabine as first-line treatment for non-keratinizing recurrent metastatic nasopharyngeal carcinoma, or as a single agent for the treatment of recurrent unresectable or metastatic nasopharyngeal carcinoma with disease progression on or after a platinum-containing chemotherapy. this really established its role in the recurrent metastatic setting, first line, toripalimab plus Gemcis. I think it's going to continue to move its way into the definitive local regionally advanced setting. I think the study evaluating toripalimab in replacement of cisplatin is very intriguing. We have not integrated those results into our clinical practice yet. A lot of these studies are done in China, given the significantly increased incidence of disease. Um, that it relative to the US, that poses some problems for FDA approval of drugs that are not, based on studies that are not done in the US, which does kind of alter what's approved landscape-wise in the US. But, I think that's the bigger and bigger shift is how we're going to integrate immunotherapy into the neoadjuvant and adjuvant setting in patients with local regionally advanced disease. I think it's going to really, really change the standard of care and potentially make that significant burden of treatment toxicity much more tolerable. What's incredibly important in treating nasopharyngeal carcinoma is that this is a multidisciplinary disease. These patients often come through an ENT clinic. They see a surgeon, usually an ENT. They see advanced nurse practitioners. They see otolaryngologists or ENTs. They see radiation oncologists like myself. I appreciate that in the slide, the radiation oncologist is the tallest. There's medical oncologists, there's pathologists. Everyone is involved in the upfront care of these patients. Each of these providers plays a meaningful role in designing the best treatment for each patient who comes into our clinic with nasopharynx carcinoma. In fact, we see the majority of our new patients at a multidisciplinary clinic that I share with a radiologist, an otolaryngologist, and a medical oncologist every week. And these are patients who are really prime candidates for that. And adding to that is the significant amount of other multidisciplinary team members who are needed to help with these patients' care that are absolutely critical to getting these patients through their nasopharynx treatment. As we've seen with patients with local regionally advanced EBV related disease, the outcomes are exceptional with 95% of patients surviving 3 years, functionally having cure of their disease. So managing all of the side effects from 70 gray of radiation, concurrent cisplatin, neoadjuvant gemcitabine, and cisplatin, in addition to the immunotherapy, is key. All of our patients see a dietitian who's absolutely critical in getting them through the very meaningful side effects of radiation and the recovery afterwards. They see speech language pathologists who help significantly in making sure that both their speech and swallow function are maintained throughout therapy. They see dentists who are key both for upfront recognition of teeth that are a high likelihood that needing future dental procedures down the line, which we certainly always want to avoid after radiation. So it's critical to get these patients in to be seen and evaluated by a dentist so that appropriate teeth can be pulled, but not only that, so they can get meaningful education on the enhanced dental surveillance that's required after definitive radiation in this patient population, fluoride trays, other mouthwashes to keep their mouth clean, more frequent dental cleanings. This is all very key in maintaining these patients' teeth, which is critical in so many ways after treatment. Endocrinologists were critical for all of the immune related adverse events that we've talked about as more and more and more of these patients are receiving some amount of immunotherapy. Audiologists to help both upfront establish what level of hearing these patients have and help monitor and manage potential cisplatin mediated hearing loss afterwards. And for patients with very locally advanced disease, the radiation may also play a very meaningful role in their hearing decline if the tumor invades towards the cochlea on either side. And then a tobacco treatment specialist. While EBV is often generative of these tumors, tobacco plays a key role in also enhancing the development of nasopharynx cancer and is an independent risk factor for the development of nasopharyngeal carcinoma. And many non EBV related nasopharynx cancers seen in the Western world are driven to some degree by tobacco. Patient advocacy is also key There are many pillars to this. There are many sides to the patient experience that we don't see. The management of nasopharynx cancer as it has evolved is now an incredibly long-term process with upfront adjuvant chemotherapy, 7 weeks of definitive chemoradiotherapy, a long recovery period, probably the addition of adjuvant therapy in the somewhat not too distant future. This is a year-long treatment process plus and really makes a huge impact in patients' lives outside of just their physical health. So getting involved in various other groups to help patients understand this and navigate through this are critical. The Head and Neck Cancer Alliance is an incredible organization that can help find these groups for your patients. We have many patient peer groups here at our institution. A lot of groups will have navigational or informational support for treatment education, various expert access platforms, and helping patients who are interested find clinical trials to help advance their care, give them more stake in their care. Peer programs are incredibly valuable for this patient population. It's a relatively unique disease in the West. Radiation is not something that many people are experienced with. It does have meaningful side effects. So having peer-to-peer support communities, both in person, if possible, if you have a large enough volume in your institution or in your community, as well as online communities, and then helping empower those patients to become potential ambassadors and members of such programs afterwards as they get better so that they can help other patients guide through the process. The cost of this care is not insignificant to the vast majority of the patient population, even those with great insurance. So, financial assistance programs, insurance and coverage advocacy, and resource navigation are critical for these patients who are touching so many different physicians and different levels of care in their journey in treating their nasopharynx cancer. Further following these patients long term to help establish and evaluate their survivorship are critical. There are many long term side effects that we've touched on, both primarily to radiation related to swallowing and speech therapy. These patients can often be doing well for 5, 10 years afterwards and then still have a decline in swallow function. Their dental health is incredibly important. As I've touched on previously, dental care is critical for this patient population who gets some level of radiation to their salivary glands, which results in xerostonia, resulting in increased dental decay. These patients get lymphedema, and physical and occupational therapy is critical. Early intervention works best. There are many other alternative strategies that can help manage this, including Botox injections, massage, all sorts of things that can really make a meaningful difference in patients' quality of life. And so thinking about this up front and how you can build your practice to be aware of these, detect these early, and get them to the relevant the relevant providers as quickly as possible is critical. The key takeaways from this talk: common signs of nasopharynx cancer are nasal blockage, epistaxis, hearing loss, but the most common presenting complaint is a painless neck mass. Most of the cases, even in the US, are EBV related, non keratinizing disease. There are people who have non EBV related disease. Well, the evidence base is thinner for those patients. We typically treat them much in the same manner as EBV related tumors. The care strategies should reflect tailored treatment plans that include supportive services and patient goals, always discussing with the patient what they want. It's critical to manage the huge burden of adverse events that these patients get as they go through care, especially in the upfront setting, getting neoadjuvant gemcitabine, definitive chemoradiotherapy. This is a lot of treatment that has a lot of side effects. So these are, critical things to think about. Community care through virtual multidisciplinary clinics or multidisciplinary clinics through your own institution, language support for relevant patients, local lab or infusion options if you can get patients treated closer to home, and encouraging the patient voice through preferences, family input, and quality of life priorities. Thanks so much for everyone for tuning in.